Welcome to The Critical Edge, the no-nonsense podcast, breaking down the latest game-changing evidence in trauma and surgical critical care to give you the edge when things get critical.
Always ready for it.
Absolutely. So, imagine this scenario. It is 2:00 a.m. on a Saturday.
Because of course it is.
Right. Always a Saturday. A 22-year-old rolls into your bay. He's got a gunshot wound to the neck right at the angle of the mandible.
Okay, high stakes right out of the gate.
Yeah. And he is hemodynamically stable, maybe a little tachycardic, but his voice is distinctly hoarse.
That hoarseness is a huge red flag.
It is. Now, 20 or 30 years ago, you would have had his neck open and prepped for major surgery in like 5 minutes flat.
Oh, without a doubt. It was automatic.
But today, you might just watch him. And that is a massive paradigm shift. So how did we get here? What is the actual concrete evidence driving that?
That's the big question.
Exactly.
Yeah.
Today, we are undertaking a highly focused, really strategic mission. We are unpacking the definitive text on the management and evaluation of penetrating neck injuries, authored by Dr. Michael T. Mardiak and Dr. L.D. Britt.
And we really need to be very clear right out of the gate about who we are talking to today in this deep dive.
Yes.
We are talking directly to you, the U.S.-trained trauma and surgical critical care surgeons.
Yeah.
You're the ones standing in the bay making those split-second decisions when the ambulance doors fly open.
One's in the trenches.
Exactly. So this deep dive is tailored specifically for your advanced clinical practice. We are going to completely bypass the basic medical school introductory noise.
Right. We know you already know your basic anatomy.
Yeah. So instead, we're diving straight into the operative pearls, the complex algorithmic decision-making, and the really fascinating and sometimes controversial statistical evolution of neck trauma protocols. Because that is what dictates exactly how you practice today.
For sure. Because, neck trauma is just a uniquely terrifying beast, isn't it?
Oh, absolutely terrifying.
When you look at Mardiak and Britt's analysis, they immediately highlight the defining characteristic of penetrating neck trauma, which is its anatomic compactness.
It is so dense.
Yeah, you have this incredibly dense, highly vascularized, neurologically critical piece of real estate. A single, seemingly isolated traumatic event, like a single ballistic trajectory from a 9mm, or just a single plunge of a knife, it can instantly result in catastrophic multi-system injuries.
It's all right there.
Right. You have the airway, the digestive tract, the major vessels supplying the brain, the spinal cord. All of it is packed into a cylinder that is barely a few inches wide.
The margin for error is essentially zero.
It really is zero.
And, to provide some historical anchoring for this, the authors take us all the way back to the 16th century.
Oh, I love this part.
Yeah, they reference the pioneering work of Ambroise Paré. So Paré reportedly treated a patient who sustained a laceration to both the common carotid artery and the internal jugular vein during a sword duel.
A sword duel. Unbelievable.
Right. Now, Paré was brilliant for his time, obviously, and he actually managed to achieve hemostasis. So the patient technically survived the acute bleeding event.
Which is a miracle in the 1500s.
It really is. But here is the kicker, and it's the exact same physiological reality we face right now. Because Paré simply ligated those vessels, he just tied them off completely, the patient was rendered permanently hemiplegic and aphasic.
Wow.
Yeah. He survived the hemorrhage, but he essentially lost his brain.
Okay, let's unpack this, because that 16th century duel really sets the stage for the exact tension you face in the operating room today.
Completely.
The human anatomy hasn't changed a single millimeter since Paré's time, but our strategic surgical approach absolutely has.
Thankfully.
Right, and that compactness we just mentioned is exactly why modern surgical strategy relies so heavily on mapping the battlefield before we ever pick up a template.
You have to know where you are.
Exactly. So Mardiak and Britt detail the zone classification system. Now, we all know the zones, obviously, but the text forces us to look at them not just as anatomical borders, but as distinct operative battlegrounds.
That's a great way to put it.
So let's start from the bottom up and talk about the surgical implications here. Zone I. We know it extends from the thoracic inlet up to the cricoid, but let's talk about why this specific area is just a surgeon's nightmare.
Yeah, Zone I is notoriously treacherous. And it's not necessarily because of what it contains, but because of what it conceals.
Right.
And how incredibly difficult it is to expose under duress. The authors explicitly note that its surgical significance lies in the fact that it encompasses the major cervicothoracic vasculature.
Big stuff.
Exactly. The subclavian vessels, the innominate artery, the origins of the common carotids, and that's alongside crucial components of the aerodigestive tract.
Everything is hidden.
Yeah, so when you have a penetrating injury here, your standard anterior sternocleidomastoid neck incision, your standard SCM approach is almost always going to fail to provide adequate proximal control.
Right, because if you have a massive hemorrhage coming from the root of the neck, you can't just clamp from above.
No, you can't.
The bleeding is coming from deep inside the chest cavity, shooting upward.
Precisely. If you are dealing with a torrential hemorrhage from a Zalzai injury, the text points out that you may need to rapidly transition your standard cervical approach into a median sternotomy.
Which is a massive move.
It is. And depending on the trajectory, maybe even a thoracic trapdoor extension.
Wow.
Just to visualize and control those great vessels before they ascend into the cervical compartments.
Yeah.
Because you are fighting the sheer anatomical depth, plus the bony shield of the clavicles and the sternum.
Yeah, getting a vascular clamp on the proximal subclavian artery behind the clavicle while it is actively bleeding, I mean, that is one of the most harrowing experiences in trauma surgery.
Without a doubt.
Which brings us up to zone 2, spanning from the cricoid up to the angle of the mandible. And, I like to think of zone 2 as the foyer of a busy house.
I like that analogy.
Yeah, it contains all the vital high-volume traffic. You've got the carotid artery, the internal jugular vein, the pharynx, the esophagus, the larynx, the trachea. It's incredibly busy. It is packed.
Highly packed.
But unlike zone 1 or zone 3, it is the most readily accessible area. It's the front door.
It really is the front door. And the text notes that the most direct surgical approach here is achieved with a standard classic incision along the anterior border of the sternocleidomastoid muscle.
The workhorse incision.
Exactly. It's the zone where if you actually have to operate, the exposure is at least straightforward compared to the extremes of the neck. You can retract the SCM laterally, retract the strap muscles and the visceral block medially, and boom, you're staring right at the carotid sheath.
Exactly. The foyer is accessible, but it's packed with critical structures. And then, as you move cephalid from the angle of the mandible up to the base of the skull, you enter zone 3.
And this is where the anatomical challenge shifts entirely.
Oh, yeah. You go from fighting the bony protection of the thoracic inlet down in zone 1 to fighting the bony obstruction of the skull base and the mandible in zone 3.
And this is where traditional surgical exposure rapidly meets its limits. I mean, the authors specifically emphasize that the internal carotid artery in zone 3 is not readily accessible surgically.
It's way up there.
It really is. As that artery ascends toward the carotid canal, it dives so deep, it gets crossed by the digastric muscle, the stylohyoid muscle, and this whole web of cranial nerves.
The hypoglossal glossopharyngeal.
Exactly. The vagus, the spinal accessory. So gaining vascular control here often requires highly specialized, highly aggressive, and frankly, highly morbid maneuvers.
We are talking about things you hope you never have to do in the middle of the night.
Absolutely.
The authors specifically mention the potential need for surgical dislocation or even frank disarticulation of the mandible.
Unhinging the jaw. Yes. You are literally unhinging or breaking the jaw just to get your instruments high enough to manage an actively bleeding internal carotid artery right at the skull base.
That sounds like a nightmare.
It is a terrifying space to operate in, which heavily influences our modern algorithms, as we will discuss a bit later.
So you have this anatomical map in your mind when that 22-year-old patient rolls in. But before you start thinking about mandibular disarticulation or thoracic trapdoors, you have to execute the initial evaluation.
Of course.
And Martiak and Britt anchor this firmly in the Advanced Trauma Life Support Framework. We all know ATLS. We know airway management always remains the absolute top priority.
Always.
But the crux of the clinical decision-making detailed in this text revolves around the rapid clinical identification of hard versus soft signs of penetrating neck injury.
Right. And the text provides a very clear, really unforgiving delineation here. Hard signs dictate mandatory urgent surgical intervention.
No questions asked.
No questions asked. You do not pass go. You do not collect $200. You go straight to the operating theater.
What are we looking for?
So these hard signs include subcutaneous emphysema or air bubbling directly from the wound, which obviously indicates a massive violation of the airway.
Yeah, that's hard to miss.
Exactly. Or an expanding or pulsatile hematoma, which tells you a major artery has a hole in it and the fascia is barely holding the pressure in.
Right.
Active, brisk, pulsatile bleeding. or a wide mediastinum on an initial chest X-ray.
These are the overt, undeniable indicators of a major vascular or aerodigestive tract disruption. And when you see these, the text is unequivocal. Diagnostic studies are not essential.
Do not delay.
You do not delay for a CT scan. You do not wait for the scanner to open up. You just take them to the OR.
Right. And on the flip side, we have the soft signs. So these prompt a more selective or expectant management approach.
Okay.
The authors list these as things like dysphagia, a subtle voice change, or mild hemoptysis. They are subtle findings that suggest something might be injured, maybe the esophagus or the recurrent laryngeal nerve, but not necessarily something that requires you to open the neck in the next 5 minutes.
But here's something in the text that I really want to pause on, because it goes against some of the reflexive actions we see in chaotic trauma base, especially from, well-meaning junior residents.
Oh, this is a crucial point.
Mardiak and Britt establish a strict, non-negotiable rule. Penetrating wounds should never be explored locally in the emergency department.
Never.
You do not take a sterile Q-tip or a hemostat and start poking around the platysma to see how deep the tract goes.
Just don't do it.
Furthermore, they mandate that the insertion of nasogastric tubes, or nasal tracheal suctioning, should be strictly withheld, if at all possible, until the induction of anesthesia in the operating theater.
Yes.
I want you to explicitly explain why this rule is so absolute. Because to an intern, dropping an NG tube might seem like a harmless, standard part of the secondary survey. Why is it so incredibly dangerous in this specific scenario?
It is a phenomenal question, and understanding the physiological mechanics behind this rule, that is what separates a good surgeon from a great one. It is exactly like pulling a single load-bearing Jenga block from the very bottom of a massive tower.
Wow, okay.
The text notes that withholding the NG tube is explicitly to limit patient gagging and coughing. But we need to understand the hemodynamics of a gag reflex in a trauma patient to really get why.
Let's break that down.
So when a major vessel like the common carotid or the internal jugular is lacerated by a bullet, the body's only defense before you get surgical control is the formation of a fragile, precarious thrombus.
A really weak clot.
Exactly. And that clot is often contained only by the tight, restrictive fascial compartments of the neck, the investing fascia, the pretracheal fascia, the carotid sheath. It is a delicate balance of pressure.
Right.
The arterial pressure is pushing out, and the fascia and the clot are pushing back. Now, if you take an NG tube and shove it down the throat of a conscious, traumatized patient, you inevitably provoke a profound gag reflex or a vigorous, violent cough.
And a cough isn't just a noise. It is a massive physiological event.
Exactly. When a patient coughs violently, their intrathoracic pressure spikes astronomically, sometimes well over 100 or 150 millimeters of mercury.
That's huge.
It is. That pressure wave is instantly transmitted up the venous system into the jugular veins, and it radically spikes the transmural pressure across the injured vessel. So you get this sudden, explosive spike in pressure, combined with the mechanical, violent movement of the larynx and trachea during the gag. That combination can instantly mechanically blow off that fragile clot.
So that Jenga block gets kicked out.
Yes. A contained, relatively stable hematoma suddenly becomes an uncontained, catastrophic exsanguination right there in the trauma bay. Blood hits the ceiling.
And you've lost control.
Completely. You lose the airway in seconds because the hematoma rapidly expands and crushes the trachea. The text is warning you, in no uncertain terms, not to turn a stable surgical patient into a messy code blue simply because of a premature diagnostic tube.
So you just wait.
You wait until the patient is in the OR, paralyzed, deeply anesthetized, and you have the neck prepped and a scalpel in your hand ready to get control.
That is a brilliant mechanical breakdown. It's really about respecting the natural, albeit incredibly fragile, tamponade until you are actually prepared to definitively fix the hole.
Exactly.
So let's move the timeline forward. The patient is stabilized, the airway is secure, we haven't provoked any calming, we haven't blindly probed the wound, and we've assessed our hard and soft signs. This brings us to a massive inflection point in the text, and honestly, a massive inflection point in the history of trauma surgery itself.
A huge shift.
If the patient has soft signs, or no signs at all, particularly in Zone 2, do you operate or do you observe? For you listening right now, this is a nuanced algorithm. You use CT scans, you observe. But for decades, this wasn't a choice at all.
It was not a choice.
It was an absolute dogmatic mandate. Every penetrating neck wound got opened. Why did the entire paradigm of our specialty shift?
To truly understand the shift, Mardiak and Britt meticulously trace the surgical data and the historical evolution of how we treat these injuries. Because, we didn't arrive at selective management overnight.
It took a long time.
It was forged in blood and bad outcomes. If we look back to the early 20th century, specifically the U.S. military campaigns during World War I, major vascular injuries of the neck had completely abysmal outcomes.
Just terrible numbers.
The authors note a staggering 30% neurologic deficit rate when carotid injuries were simply treated by ligation, tying off the vessel, just like Ambroise Paré did.
A 30% stroke rate. That is catastrophic. And why was that happening? Because we know some people can tolerate a tied-off carotid.
They can if they have robust collateral flow through the circle of Willis. But you don't know who has an intact circle of Willis in a trench in 1917.
Right.
And the surgical tools for delicate vascular repair simply didn't exist in the frontline military hospitals back then. The turning point didn't really arrive until the 1950s during the Korean War experience.
Okay, so a few decades later.
Right. This is when vascular repair techniques were finally popularized and proven effective in the field. You had the advent of fine vascular silk, antraumatic DeBakey clamps, and surgeons who were finally trained to sew vessels together rather than just clamp and tie them.
Makes a huge difference.
It did. The superior results of repairing rather than ligating the carotid were immediately recognized. The stroke rates plummeted.
And that profound success in the military theater directly influenced civilian trauma protocols back home.
It always does.
The authors point to 1956, to the landmark work of Fogelman and Stewart. They published the first major civilian report on carotid injuries, pulling from their experience in Dallas. They concluded that operative intervention was necessary, and critically, they found that the mortality rate increased significantly the longer surgery was delayed. This single report essentially became the bedrock foundation for mandatory exploration of the neck. For the next 2 decades, the standard of care was unequivocal, dogmatic, and universally taught. If the platysma muscle is violated by a penetrating object, you open the neck, period. End of discussion.
It was incredibly dogmatic. It was taught as an absolute surgical truth. But what's fascinating here is how the trauma community eventually began to interrogate its own dogma.
Yeah, we started looking at the actual outcomes.
Exactly. By the mid-1970s, reports challenging this mandatory exploration policy began to surface in the literature. This pushback was driven by the growing realization that this approach carried a massive, largely unspoken cost.
And negative rates.
Yes, the text dissects the 1970s literature that revealed the glaring, undeniable flaw of mandatory exploration, incredibly high negative exploration rates. We are talking about subjecting healthy patients to major morbid cervical surgery, general anesthesia, the risks of intubation, and prolonged hospital stays for absolutely no therapeutic benefit.
Let's look at the actual numbers the authors provide, because they are staggering when you think about modern practice.
They are.
They cite Soletta, who reported on a series of 246 patients undergoing mandatory neck exploration. The negative exploration rate was 63%.
63%.
Let that sink in for a second. More than 6 out of every 10 patients who were rushed to the OR and had their necks sliced open had absolutely nothing wrong with them that required a surgical repair.
It's wild.
And it wasn't just him. Bishara reported a 53% negative rate. Ilarding reported a 56% negative rate. These are massive, unjustifiable numbers of non-therapeutic operations.
It's staggering, right? Imagine putting 6 out of 10 perfectly fine patients through a major neck exploration. The morbidity was unjustifiable.
So many risks.
You risk injuring the recurrent laryngeal nerve, causing vocal cord paralysis. You risk wound infections. You are tying up operating rooms and anesthesia teams for hours on end, essentially doing a diagnostic procedure with a scalpel.
Yeah, that's not good medicine.
However, Mardiak and Britt are careful to present the other side of the coin, the nuance that kept the mandatory debate alive for so long.
Right, there's a reason people still argued for it.
Exactly. Even with that 63% negative rate, Soletta found 13 occult injuries. These were major injuries, like a small hole in the esophagus or a non-bleeding venous laceration that had absolutely no clinical signs prior to the incision.
Right, the patient looked completely fine, but there was a time bomb in their neck.
Exactly. Bashar's series found that 23% of the patients explored mandatorily had completely unsuspected injuries, mostly isolated venous injuries or isolated pharyngoesophageal injuries.
Wow, 23%.
So the old guard, the advocates for mandatory exploration, looked at those missed injuries and argued forcefully that the morbidity of a negative exploration, the scar, the overnight stay, was absolutely worth it to prevent missing a single catastrophic injury like an esophageal leak that would kill the patient a week later from mediastinitis.
Which is a valid fear.
It is. Obaid's retrospective review supported this stance, highlighting the morbidity and hospital days associated with negative explorations, but acknowledging that missed injuries still occurred if you didn't look.
It was a true surgical catch-22. You're damned if you do, damned if you don't. But then the text introduces Meyer's 1987 prospective trial, which really throws a wrench into the selective management argument.
It does.
And I want to push back on this a bit, because Meyer's data is terrifying. Meyer looked at 120 patients. In the group managed selectively, meaning they didn't just open the neck, but relied on angiography, endoscopy, and esophagography to rule out injuries. They missed 6 major vascular injuries across 5 patients.
That's a huge miss rate.
These were injuries that were not expected preoperatively and were missed by the diagnostic modalities of the time. Meyer looked at those misses, saw the catastrophic potential, concluded the selective management was inherently dangerous, and passionately advocated for a return to mandatory exploration.
A huge step backward, potentially.
Right, so let's be real here. For the trauma surgeon listening today, who routinely practices selective management and rarely opens an asymptomatic neck, how do we reconcile Meyer's terrifying findings from 1987 with our modern hands-off practice? Are we just missing things?
That is the critical methodological question, and it is entirely fair to be skeptical of selective management when early studies showed such dangerous miss rates. But we have to look at the tools they were using.
Right, 1987 technology.
Exactly. How do we trust selective management today? The text reconciles this by demonstrating the evolution and the proven statistical reliability of the clinical physical examination in much more recent, robust, and methodologically sound cohorts.
The physical exam got better.
Well, our reliance on it and standardization of it did. You have to remember, the earlier studies from the 70s and 80s often lacked the rigorous, standardized, highly sensitive physical exam protocols we utilize today. They also lacked high-resolution CT scanners. The authors guide us through the more contemporary literature to prove this point. They cite Beich, whose retrospective review demonstrated that a negative physical examination alone ruled out 99% of vascular injuries.
99%.
Yes, out of 71 angiograms performed based purely on a negative exam just to check, only one single patient required an operative repair.
And the data gets even stronger as we move into the 90s and 2000s. The text brings in Azwache's series. Now listen to this number. Azwache demonstrated a 100% negative predictive value for the physical examination in detecting surgically significant vascular injuries.
Wait, 100%?
Yes, 100%. Think about the statistical power of that statement. A 100% negative predictive value. That means if the exam is truly negative, no hard signs, no soft signs, normal pulses, normal voice, no expanding hematoma, the chance of there being a vascular injury requiring surgery is statistically 0.
That is incredible.
When they compared the physical exam directly to formal angiography, the physical exam showed a sensitivity of 93% and a negative predictive value of 97%. In Azwache's entire series, not a single patient with a negative physical examination required a vascular repair, regardless of whether the injury was in zone 1, 2, or 3.
And we see this replicated. Sakaran reported a missed injury rate of merely 0.7% with physical examination alone. Jarvik reported a sensitivity of 93.7% for physical exams detecting clinically significant vascular injuries.
So the data is solid.
It is. If we connect this to the bigger picture, the methodological evaluation of these key studies provides a definitive, undeniable takeaway for the modern surgeon. A meticulous, astute, highly directed physical examination is profoundly sensitive and specific.
So we can trust our hands and eyes.
Yes. The era of mandatory exploration for asymptomatic, stable patients is over. It is dead. The routine mandatory exploration of asymptomatic Zone 2 injuries is now considered an outdated, unjustifiable expenditure of time, effort, and patient morbidity.
Good riddance.
As Mardiak and Britt conclude on this point, routine use of ancillary diagnostic procedures or mandatory exploration offers absolutely no advantage over experienced, expectant management for the truly asymptomatic patient.
Okay, so a rigorous physical exam is king. If they have a normal exam, you can observe. But what about that gray area?
The soft signs.
Right. What about when we have those soft signs? The subtle voice change, the mild dysphagia, or maybe a trajectory that just looks incredibly dangerous on the surface. If we aren't routinely opening every neck to look, we need highly reliable eyes under the skin. We need imaging.
We absolutely do.
So how has imaging evolved to support this highly selective management paradigm we just established? The text transitions into evaluating the modalities that actually make selective management safe.
It does, and it starts by looking at early attempts with duplex scanning.
Ultrasound.
Yes. The text references Ginsburg's prospective double-blind evaluation of stable patients across all three zones. They demonstrated that duplex ultrasound scans had 100% sensitivity and an 85% specificity for vascular injuries.
Which sounds pretty great.
It is a non-invasive, widely accessible tool. You can roll the machine right into the trauma bay. But there's a catch, and the authors know it. Duplex is highly operator-dependent.
Oh, for sure.
A great ultrasound tech might catch a tiny intimal flap, but a tired resident at 3 a.m. might miss it entirely. Plus, ultrasound is virtually useless for the aerodigestive tract. It can't tell you if the esophagus has a hole in it.
Exactly. Which is why the narrative quickly shifts to the true imaging revolution that has redefined our algorithms over the last 2 decades.
Yeah.
Multidetector or multi-slice helical computed tomography, MHCT, and CT angiography, CTA.
Yes. MHCT has fundamentally changed trauma surgery.
I want to spend some serious time here because MHCT is presented by the authors as the modern de facto standard.
It really is.
The text states that virtually every body region has been studied this way, and its wide availability, sheer speed, incredible image quality, and ability to reconstruct images in multiple sagittal and coronal planes have made it indispensable.
We use it for everything.
They cite Minera's prospective study of 60 patients, which reported that helical CT had a sensitivity of 90%, specificity of 100%, and a negative predictive value of 98%.
Those are excellent numbers.
That sounds fantastic. It sounds
Yeah.
like the Holy Grail. But the text also includes studies that we really need to view with a highly critical methodological eye. We can't just accept everything published.
No, we absolutely cannot.
For example, the authors cite Mazalewski's prospective evaluation, which claimed a 100% sensitivity for CT scans in evaluating penetrating neck injuries. 100% sensitivity. That means it never ever misses an injury.
Right.
But look closely at the data provided in the text. This sweeping conclusion was drawn from a sample size of only 14 stable patients. 14.
That's nothing.
As an attending surgeon reading the literature, you cannot responsibly adopt a 100% sensitivity claim and change your practice based on an N of 14. It's absurd.
Yeah.
You can't base your entire trauma protocol on 14 guys.
You are absolutely right to push back on that, and it raises a vital point about how we interpret surgical literature in our field. A sample size of 14 patients lacks any meaningful statistical power to generate a 100% sensitivity claim that can be generalized to a broader, diverse trauma population.
The math just isn't there.
The confidence intervals on a sample that small would be massively wide. It could be 100% or it could be 40%. We just don't know.
Right.
The text validates this skepticism by immediately contrasting Mazalewski's tiny study with Hollingworth's much more rigorous meta-analysis. Hollingworth looked specifically at CTA for the detection of carotid and vertebral lesions in trauma and concluded that, at the time, there were simply insufficient, high-quality, adequately powered data to definitively comment on the true sensitivity or specificity of CTA in this setting.
Exactly. And the methodological critiques in the text don't stop there. They analyze Inaba's prospective evaluation of MHCT for penetrating neck wounds.
Inaba's a big name.
Now, Inaba is a heavy hitter in trauma literature, for sure. His study concluded that essentially no injuries were missed by CT imaging. It was a ringing endorsement. But again, look at the limitations the authors explicitly point out. The follow-up for these patients was incredibly short, a mean of only 33 days.
That's just a month.
Furthermore, the follow-up was incomplete, capturing only 84% of the evaluated population.
And this raises an important question. That is a massive red flag in a trauma population.
It's a huge red flag.
Yeah.
An 84% follow-up rate at just 33 days introduces a profound risk of attrition bias. We're dealing with trauma patients. They're often young, sometimes transient, and notoriously non-compliant with follow-up appointments.
Very true.
The 16% of patients lost to follow-up in an ABA study are the exact patients we worry about. They could easily harbor missed injuries, slowly expanding pseudoaneurysms, or evolving arteriovenous fistulas that simply haven't become symptomatic or ruptured within that tiny 1-month window.
That is a critical textbook appraisal of the literature. You cannot definitively state no injuries were missed when you haven't even looked at 16% of your cohort and you've only followed the rest for a single month. A pseudoaneurysm might take 3 months to blow.
Exactly.
However, despite these very real study flaws and methodological limitations, Mardiak and Britt ultimately arrive at a consensus. Based on the totality of the evolving evidence, the sheer speed of modern scanners, and the clinical reality of its utility in a busy trauma center, MHCT is undeniably considered the screening test of choice for the patient not requiring immediate surgical exploration.
It's the best tool we have.
It is. The true power of the MHCT isn't just seeing the injury. It's the ability to delineate the exact missile tract and show its precise relationship to critical structures. It allows the surgeon to intelligently, calmly plan the next steps rather than exploring blindly.
Which brings us to the definitive clinical algorithm provided next. This is the bread and butter.
Let's get into it.
Let's walk the listener through exactly how Mardiak and Britt recommend managing these patients based on all this history and data. The algorithm is remarkably clear. Step 1. Physical exam. If the patient has hard signs, a pulsatile hematoma expanding before your eyes, active arterial bleeding hitting the wall, bubbling air from the trachea, they go directly to the operating room.
Yeah.
Period.
No stops.
You don't scan them, you operate.
Correct. And if they have absolutely no hard or soft signs, their voice is fine, they are swallowing their saliva, their exam is pristine, they can be safely observed or even discharged after a period of observation.
Easy enough.
But the nuance, the real intellectual challenge lies in the patients who present with soft signs or where the trajectory on the surface just looks highly concerning. For these patients, the algorithm dictates an immediate MHCT or CTA.
Yeah.
And here, the text introduces a crucial, highly specific, quantifiable definition that every trauma surgeon must memorize. The definition of proximity.
Yes, proximity. It's not just it looks close. Proximity is defined specifically and mathematically as a wound tract that passes within 5 millimeters of a major vascular or aerodigestive structure of interest.
5 millimeters.
5 millimeters. Why 5 millimeters? Because we know from ballistic physics that a bullet creates a shock wave, a temporary cavity of tissue destruction that extends beyond the permanent physical hole it leaves behind.
The blast effect.
Exactly. The kinetic energy transfer can severely contuse an artery or necrotize an esophagus, even if the bullet didn't directly touch it.
That's the exact mechanism. If the CT imaging shows the tract is obviously away from major structures, say, it just passes through the subcutaneous fat and the trapezius muscle, no specific therapy or further diagnostic workup is initiated. You wash it out and watch them.
Simple.
But if you hit that 5 millimeter proximity threshold, or if the CT study is equivocal due to massive artifact scatter, when retained metallic bullet fragments cause those bright white streaks that obliterate the image quality, that finding mandates further invasive investigation.
You can't just say, well, I can't see it because the bullet artifact, so it's probably fine.
Exactly. You can't guess. The text states that this further investigation is at the surgeon's discretion, but typically involves formal catheter-based angiography to definitively rule out a vascular injury.
Or EGD.
Yes, esophagogastrodiadonoscopy, or EGD, to look at the digestive tract, or fiber optic bronchoscopy, FOB, to look inside the airway, depending on exactly what structure the tract is threatening.
That 5 millimeter rule is the quantitative anchor in the modern selective management algorithm. It takes the guesswork and the subjective, I think it's okay, out of interpreting the CT scan.
It standardizes it.
So we've navigated the diagnostic algorithm, we know the history, we know when to observe, when to scan, and when to operate. Now, we must transition from diagnosis to the operating theater itself.
The action phase.
When the decision is made to explore, when there are hard signs or a positive scan, how do we systematically manage the structures most likely to be injured in tandem? Mardiak and Britt provide an absolute masterclass on aerodigestive and soft tissue injuries.
They do. Let's start with the airway, because as the authors reiterated early on, and as ATLS dictates, optimal airway management is always the top priority.
Always.
And these injuries are not rare anomalies. The authors cite Asensio's data indicating that aerodigestive tract injuries are seen in 10% of all penetrating neck injuries.
10%.
That is 1 in 10 patients. Because of the incredibly close proximity of the trachea and the esophagus, they share a common party wall if one is injured. You must maintain an extremely high index of suspicion for the other.
When it comes to securing that compromised airway, the text outlines a very strict hierarchical approach. In a patient requiring urgent airway management, the absolute first line, the best, safest option, is a translaryngeal endotracheal approach, meaning a standard intubation through the mouth. Okay.
But the authors add a critical caveat.
This must specifically be performed by a skilled practitioner. An airway expert, an attending anesthesiologist, a senior trauma surgeon, a seasoned CRNA should always make the first attempt at rapid translaryngeal intubation. You don't let the medical student try to intubate a bubbling neck wound.
Right, because if you mess around and cause more bleeding, you lose the view entirely. But we know that a clean translaryngeal intubation isn't always possible in a traumatized, massively bleeding airway where the anatomy is completely distorted by hematoma and edema.
So what's next?
So what is the next step in the hierarchy? If you are in a true emergency setting, the patient is desaturating, and the translaryngeal approach fails or is anatomically impossible, the surgical airway of choice is a cricothyroidotomy.
The cricket?
It is rapid, it requires minimal dissection, and it is life-saving. You make a vertical skin incision, a horizontal stab through the cricothyroid membrane, dilate it with your finger or a scalpel handle, and drop a tube in.
Boom! Airway secured. Now, interestingly, the text specifically addresses tracheostomy, placing it much further down the hierarchy for acute management. A formal tracheostomy takes time.
Too much time.
It requires careful dissection of the thyroid isthmus and the pretracheal fascia. The authors state a tracheostomy should be considered in an adult only when there is an urgent need for an airway in a patient whom you highly suspect might have a partial laryngotracheal separation.
A very specific scenario.
Why? Because if the trachea is partially separated from the larynx, manipulating the neck for a cricothyroidotomy or shoving a tube down from above might complete the tear,
Which is terrifying.
causing the distal trachea to retract deep into the mediastinum where you can't reach it. And even in that highly specific, terrifying scenario, the authors reiterate that a gentle attempt should still be made, if possible, by an airway expert to perform a careful translaryngeal intubation first over a flexible fiber optic bronchoscope.
That is the ultimate test of airway skill right there. But the text goes beyond just securing the plastic tube. It delves deeply into the definitive surgical management of the injured laryngeal structures once you are in the OR.
Here's where it gets really interesting.
They bring up Bent's laryngeal injury classification system, which grades injuries from Group 1 to Group 5 based on an extensive 18-year retrospective experience. And this classification dictates your surgical approach.
Okay, lay it out.
Group 1 is your minor hematomas, or small mucosal lacerations without any cartilage fracture. Group 2 involves more significant edema and non-displaced fractures visible on CT. Group 3 escalates significantly to massive edema, exposed cartilage in the airway lumen, vocal cord immobility, and displaced fractures.
Group 4 is essentially Group 3, but with massive destructive trauma to the mucosa itself, or more than 2 fracture lines, making it highly unstable. And Group 5 is the absolute nightmare scenario we just alluded to. Complete laryngotracheal separation, the airway is completely severed in two.
The crucial clinical pearl derived from Bent's classification, the thing that every surgeon must internalize, is the timing of the repair. The text explicitly warns that treatment delays in laryngeal injuries beyond 48 hours lead to significantly inferior functional results.
48 hours, that's the window.
The mucosa of the airway heals very poorly if it isn't perfectly approximated. Precise mucosal coaptation, sewing the pink edges back together, and meticulous fracture reduction with mini plates or wire must be performed at the time of the initial exploration, if at all possible.
You have to do it right the first time.
This is the only way to preserve long-term phonation so the patient can speak, and maintain airway patency so they don't develop crippling subglottic stenosis later.
The authors acknowledge that delays often occur in the real world because the patient is too severely injured elsewhere. Maybe they have a shattered spleen or a massive head bleed to undergo a meticulous 2-hour laryngeal reconstruction immediately. But that 48-hour window is a critical prognostic benchmark. You have to get back in there and fix it before the tissue becomes too friable and scarred to hold a suture.
Exactly. Time is function. Now, if the airway is the most immediate, loud, obvious threat, the esophagus is undoubtedly the most insidious silent killer in the neck.
I want to highlight a truly terrifying reality presented in the text regarding esophageal injuries. The authors cite Weigelt, who reported that 7 out of 10 patients, 70% of patients with a documented surgically confirmed penetrating esophageal injury had absolutely no signs or symptoms upon presentation.
7 out of 10. Unbelievable.
No dysphagia, no spitting up blood, no subcutaneous air. 70% were completely clinically silent. And here's why that is so dangerous. The esophagus does not have a serosal layer like the small intestine. It is just muscle and mucosa.
Very fragile.
If you miss a hole in the esophagus, the negative intrathoracic pressure generated during breathing literally sucks saliva, bacteria, and gastric juices down into the mediastinum.
That's a disaster.
The patient rapidly develops fulminant necrotizing mediastinitis, which carries a horrific mortality rate. Because the clinical physical exam is so completely unreliable for the esophagus, how do we diagnose it? We can't just rely on our hands here.
We can't. The text evaluates our diagnostic tools rigorously. Weigelt noted a false negative rate of approximately 20% for either endoscopy or contrast esophagography when used as a standalone test.
1 in 5.
That means 1 in 5 injuries was missed by a single test. It wasn't until both procedures were combined that the false negative rate finally decreased to 0%. The authors also reference Armstrong's retrospective series of 23 patients. Contrast esophagograms alone were only 62% sensitive, which is completely unacceptably low for an injury that will kill your patient in 3 days.
Yeah, you can't rely on 62%.
Rigid esophagoscopy, however, was 100% sensitive.
But using a rigid, straight metal pipe to look down a traumatized neck is dangerous and technically demanding.
It takes a lot of skill.
The text notes a modern shift in technique. With the advent of advanced fiber optic technology, high-definition cameras, and greater operative experience, flexible endoscopy combined with water-soluble contrast has essentially supplanted the rigid scope.
It's much safer.
It's much safer, it requires less neck extension, and it's highly effective. But here is the absolute most critical clinical pearl for the surgeon performing that flexible endoscopy. And if you listen to nothing else today, listen to this. The text emphasizes the absolute necessity of visualizing the proximal 3 to 5 centimeters of the cervical esophagus immediately inferior to the cricopharyngeal constrictor.
This is a classic pitfall.
Why? Because this specific, highly vascularized area is notoriously and easily missed during the routine insertion and withdrawal of the scope. When you push the scope past the vocal cords, the patient often gags, the cricopharyngeal spasms, and the scope forcefully slides past that proximal 3 to 5 centimeters way too quickly to see anything.
You just blast right past it.
The text mandates that this specific area must be specifically, slowly, and deliberately inspected, inflating air and pulling back millimeter by millimeter.
It requires extreme patience. And if you do find an injury, the surgical repair follows strict, unforgiving, time-tested principles. The text dictates minimal debridement. You only cut away what is obviously dead because the esophagus has tenuous blood supply, largely segmental.
Right.
If you debride too much, you create a massive defect you can't close. This is followed by a primary closure. Crucially, this closure must absolutely be done in 2 distinct layers. You run an inner absorbable layer to mucosa to create a watertight seal, and you follow that with an outer non-absorbable suture layer through the muscularis to provide strength and relieve tension on the mucosal layer.
And what if that esophageal wound is sitting right next to a tracheal wound? We talked about that shared party wall earlier, the aerodigestive proximity. A bullet often passes right through both.
That is a setup for a devastating, life-altering complication, the tracheoesophageal fistula.
A TE fistula.
If you sew the trachea closed and you sew the esophagus closed, and those 2 suture lines sit right on top of each other, they will almost certainly break down, rub together, and fistulize into each other during the healing process. Every time the patient swallows, saliva goes into their lungs.
That's a nightmare.
The text provides a hard, unbreakable rule for this scenario. For concomitant tracheal and esophageal wounds, the interposition of viable endogenous tissues, specifically a vascularized muscle flap, is essential.
You have to build a wall.
Yes. You must physically separate the 2 suture lines with healthy, well-vascularized tissue. Typically, surgeons will mobilize a slip of the sternocleidomastoid muscle or detach the omohyoid or one of the strap muscles and sew it in between the trachea and the esophagus.
That's a great technique.
This provides a physical barrier and a rich blood supply to promote healing and prevent them from fistulizing. It is a mandatory step. Do not skip the muscle flap.
Okay, so we've secured the bloody airway, we've carefully diagnosed and repaired the sneaky, silent esophagus in 2 immaculate layers, and we've interposed a beautiful muscle flap. We've managed the aerodigestive tract. Now, we must turn our attention to the ultimate, immediate bleeding threats, the major vascular structures. We are moving into operative strategies for the carotid artery and the internal jugular vein.
The operative approach here is, again, entirely dictated by the zone of injury. For the incredibly busy Zone 2, the text details the standard workhorse incision, a long incision along the anterior border of the sternocleidomastoid muscle. You want the patient's head turned to the opposite side to stretch the muscle out.
Makes sense.
And the text notes a very simple yet incredibly helpful maneuver, placing a towel roll under the patient's shoulders. This extends the neck, brings the structures anteriorly, and optimizes your exposure immensely.
It's the little things that save you time.
Exactly. As you dissect down through the platysma and the investing fascia, you will encounter the common facial vein crossing your field. The text is clear here. Do not waste time trying to preserve it. This vein can and should be safely ligated and sacrificed to allow complete, unhindered visualization of the common carotid, the carotid bulb, the proximal, internal, and external carotids, and the internal jugular vein.
So once you have exposure, you dissect out the vessels, you get your umbilical tapes around them for proximal and distal vascular control, and then you open the hematoma. Now you face the great debate in cervical vascular trauma. Do you repair the injured vessel or do you ligate it?
The million-dollar question.
This brings us all the way back to that historical 30% stroke rate from WWI. The text cites multiple massive modern reviews, Leakweg and Greenfield, Unger, and Brown. All of these studies conclusively confirm that revascularization repairing the artery yields significantly lower morbidity and mortality rates compared to ligation. The primary goal, the default setting for a trauma surgeon, is always to repair.
And how you repair it matters immensely. The text outlines several options based on the degree of tissue destruction. Direct, primary suture repair with a fine proline is ideal if it's a clean knife wound.
Sure.
But if it's a gunshot wound with tissue loss, primary repair is often not possible without putting the vessel under immense tension or causing a severe stenosis, narrowing the lumen. When an interposition graft or a patch is needed, the authors recommend using an autologous vein patch.
And ironically, you can often take that patch from the adjacent facial vein you just mobilized and sacrificed earlier.
Exactly, it's right there. Alternatively, you can utilize synthetic PTFE or bovine pericardium. Interestingly, the text notes a significant difference here between trauma surgery and elective vascular surgery.
Oh, what shunts?
Yes. In the trauma setting, intraluminal shunts, those plastic tubes placed inside the artery to maintain blood flow to the brain while you sew, are not routinely used during these repairs. Unlike an elective carotid endarterectomy, where you have time to carefully place a shunt in a trauma setting, the risk of a shunt dislodging an intimal flap, introducing air, or taking too much time to place often outweighs the benefit.
You just clamp and sew.
The brain can usually tolerate the cross-clamp time if you work efficiently.
So if the data so strongly, overwhelmingly supports repair, when, if ever, is it acceptable or necessary to completely ligate an injured carotid artery? Because there are times when you have to do it.
There are, and the text is extremely precise and cautious about this. The decision is incredibly complicated by our poor ability to discriminate clinically between severe reversible ischemia and an evolving irreversible infarction in the acute chaotic setting of the OR. We don't have real-time MRI in the trauma bay.
No, we don't.
However, the author stressed that ligation is reserved only for two highly specific, dire scenarios. First, for patients who present with devastating fixed neurologic injuries, meaning they already have a massive irreversible stroke.
Okay, why?
Because revascularizing an area of established dead brain infarction can lead to a lethal phenomenon called hemorrhagic conversion. Reintroducing high-pressure arterial blood into dead brain tissue causes massive bleeding into the brain parenchyma, turning a white stroke into a red stroke and killing the patient.
You're essentially pumping blood into a sponge that can't hold it.
Precisely. The second scenario where ligation is preferable is in the complete absence of prograde flow from the distal internal carotid artery at the time of surgical exploration. If you open the vessel, clear the clot, and there is no back bleeding coming down from the brain, that tells you the distal artery is completely thrombosed all the way up into the skull.
It's blocked.
If there is no prograde flow, there is no viable distal bed to revascularize. In that case, you ligate. If there is robust back bleeding, that is a good indication that the distal bed is viable and you should repair it.
That's the carotid. It's high stakes.
Right.
But what about the massive internal jugular vein sitting right next to it? It bleeds just as much, if not more, volume.
For the internal jugular, lateral venorrhea, which simply means sewing the laceration closed laterally with a running proline, is the preferred method if it's a simple laceration. However, the threshold for simply ligating the jugular vein is much, much lower than with the arterial side.
Oh, really?
Ligation of the IJV is considered a completely reasonable, standard, and acceptable alternative, specifically if the transection is nearly complete from a blast injury, or if attempting a complex repair would result in narrowing the luminal diameter by more than 50%.
Why is it so much safer to tie off the jugular compared to the carotid?
Because of the incredible redundancy of the venous system, the venous collateral drainage in the head and neck, the contralateral jugular, the vertebral plexus, the external jugulars, is usually incredibly robust and completely sufficient to tolerate a unilateral IJV ligation without causing significant cerebral edema or long-term stick away.
Before we move on from the nitty-gritty of operative technique, the text mentions a few highly specific, zone-specific maneuvers that every trauma surgeon needs to have in their mental back pocket. We talked about the nightmare of zone I earlier, and the text reiterates that if you are exploring the neck and realize the injuries extend proximally, deep down into the thoracic outlet, you manage that by extending that anterior SCM incision straight down the midline, splitting the sternum into a median sternotomy.
Yep.
Or, if it's on the left side, extending it out laterally along the clavicle to create a thoracic trapdoor.
It's a massive exposure, but it's the only way to get control of the subclavian artery before it exsanguinates into the chest.
And what if you have a transcervical gunshot wound? A bullet that enters the left side of the neck, crosses the midline right over the trachea, and exits the right side, creating the potential for bilateral catastrophic vascular injury.
For a transcervical trajectory, the text recommends abandoning the unilateral SCM incision and utilizing an extended transverse collar incision. It's very similar to the incision you use for a standard thyroidectomy, much wider, from SCM to SCM.
A huge collar.
This transverse approach allows you to obtain bilateral vascular control easily from one single position and provides excellent access to the trachea and esophagus in the midline.
It's all about anticipating the required exposure, reading the trajectory of the weapon, and opening appropriately before you lose control of the hemorrhage. Mardiak and Britt provide a comprehensive, highly strategic anatomical roadmap for navigating these incredibly stressful life-or-death operative scenarios.
They absolutely do.
All right, we are going to pause the deep dive narrative for a moment to address some practical, rapid-fire clinical scenarios. We've designed these to be directly relevant to your daily practice, anticipating the real-world application of the text we've just unpacked.
So let's hear them.
Let's look at this first question from the perspective of our listener standing in the bay. If I'm exploring a patient with a penetrating knife injury at the base of the neck, on the left side, a classic deep zone eye injury, what specific, easily missed anatomical injury does the text warn I should be hunting for?
That is a fantastic, highly anatomic question that differentiates a novice from a master surgeon. The text specifically highlights the thoracic duct. The thoracic duct is the main vessel of the lymphatic system. It sits right there at the base of the left side of the neck, deep to the sternocleidomastoid, arching over the subclavian artery to enter the junction of the left internal jugular and left subclavian veins.
It carries all the chyle, all the dietary fat from the gut back to the bloodstream.
Exactly. The clinical pearl here is that it is incredibly notoriously difficult to identify during an acute bloody trauma exploration.
Why is that?
Because the classic milky white chylous drainage you might expect to see from a severed lymphatic duct is almost always completely diluted and masked by the sheer volume of bright red arterial blood and disrupted weeping soft tissue in the wound bed. It just looks like normal serum or blood. If you don't actively look for it, if you don't specifically inspect that junction in a left-sided zone I injury, you will absolutely miss it.
And what happens if you miss it and close the neck?
The patient will inevitably develop a massive chylothorax where liters of chyle fill the chest cavity, compressing the lung, or they will develop a high-output chylocutaneous fistula out of their neck incision postoperatively. It leads to severe malnutrition and immunodeficiency. You have to find it, and you simply ligate it with a silk tie.
Spot on. Hunt for the thoracic duct on the left. Here is question 2, dealing with a highly complex scenario we touched on earlier. According to the text, if a patient presents with a zone 3 injury way up high above the angle of the mandible, and they have overt hard signs of a vascular injury, like a massive pulsatile hematoma or active arterial bleeding from the ear or mouth, does the algorithm recommend immediate open surgical exploration despite the extremely difficult access we discussed?
The answer to that is a resounding no, and the text cites Ferguson's data to explain exactly why the specific paradigm changed. Ferguson looked closely at 72 patients with penetrating neck wounds. For those specific patients with zone 3 injuries presenting with hard signs, immediate open surgical exploration is often futile and incredibly highly morbid.
Right.
As we discussed, getting vascular control up there requires unhinging the jaw, drilling out the skull base, and risking massive cranial nerve damage, often while the patient is actively bleeding out on the table.
It's a bloodbath, so what do we do instead?
Ferguson's data conclusively demonstrated that these specific patients, even with hard signs, should be taken for emergent, formal, catheter-based angiography. The rationale is that high internal carotid or distal vertebral artery injuries at the skull base are incredibly difficult to access with a scalpel, but they're often highly amenable to endovascular angiographic treatment.
So IR takes it.
Yes, the interventional radiologist or endovascular surgeon can snake a catheter up from the groin and deploy a covered stent across the hole in the carotid or embolize a bleeding external carotid branch from the inside out. You achieve instant hemostasis, saving the patient the massive, disfiguring morbidity of jaw dislocation and skull-base dissection.
Which perfectly bridges us to our conclusion for today's deep dive. Let's summarize the core game-changing tenets of Mardiak and Britt's text for the surgical listeners standing in the bay today. Number 1. The historical era of mandatory exploration for all penetrating neck injuries is definitively over. It is a relic of the past. An astute, rigorous, heavily documented physical examination can rule out 99% of clinically significant vascular injuries. Trust your exam.
Trust your hands.
Number 2. If you have soft signs or a concerning trajectory, multi-slice helical CT, MHCT, is your absolute best friend. Look specifically and meticulously for that crucial 5 millimeter proximity threshold to dictate further invasive workup. Number 3. In the OR, if you're repairing a combined tracheal and esophageal injury, you absolutely must physically separate those two suture lines with a viable endogenous muscle flap to prevent a catastrophic fistula. And number 4. Default to repairing the carotid artery with primary suture or a vein patch unless the patient already has a devastating fixed neurologic deficit or an absolute absence of prograde flow.
It truly is a masterful synthesis of complex anatomy, historical trial and error paid for in morbidity, and modern high-resolution imaging capability. The text provides a clear, evidence-based algorithm that replaces the sheer panic of a bloody neck wound with a calm, step-by-step protocol.
It gives you a roadmap when the pressure is on. But I want to leave you with a final thought to mull over. We've covered the established science, the rigid rules of the text, but where are we going next? So what does this all mean?
The text briefly mentions, almost as an aside in the very end of the chapter, that the role of endovascular therapy for penetrating cervical wounds is evolving. They note that the vast experience gained from treating atherosclerotic disease with stents will inevitably spill over into trauma care.
Like we just discussed with Zone 3.
We just talked about stenting Zone 3 injuries. But here's the provocative thought, the real-world collision of technology and patient demographics. Endoluminal stents placed in young arteries require lifelong, rigorous patient follow-up. They require daily antiplatelet therapy.
Right.
Think about your actual patient population in the trauma bay. We are frequently treating young, often non-compliant, high-risk populations, people who miss clinic appointments, who can't afford Plavix. How do we, as a surgical community, balance the immediate, undeniable surgical elegance of dropping a stent into a Zone 3 carotid blowout, saving them a massive operation today, against the harsh, unforgiving clinical reality of a 22-year-old trauma patient who may never, ever return for the required lifelong follow-up CTA?
That's a scary thought.
We are risking a catastrophic stent thrombosis and a massive stroke a year from now. Is the immediate, elegant, technological fix worth creating a long-term, potentially lethal blind spot? It is a question the literature hasn't fully answered yet, but one every single trauma surgeon must grapple with in real time when they call interventional radiology.
And that is exactly the kind of critical thinking, beyond just the technical steps, that keeps you sharp. Thank you for joining us on this deep dive into Mardiak and Britt's definitive work. We hope this extensive strategic review gives you the clarity, the historical context, and the surgical confidence you need the next time those bay doors open and a neck trauma rolls in. Stay sharp, trust your physical exam, and we'll see you on the next deep dive.